Okay, people, I'm here at Clinicals. I feel like I'm incognito, that I'm just trying to do this in the black market or something. But I have been so busy this week trying to get all the PN ones ready for their final skills pass off. And so I kept putting this off and putting this off. And this morning at 4:30, when I'm driving to work, I'm sitting there going, oh yeah, I forgot that overview. So I'm going to try and give this to you relatively quickly. I hope you can see me. I hope you can hear me, because nobody else in their right mind is up at 7:42 on a Saturday morning. No, nobody in their right mind. Okay, so as you know, we have the genitourinary lecture this week, and so this is exam number 8. So there were some terms that I wanted to review with you before we really get into the discussion on the lecture part. First of all, there's dysuria. Yeah, I keep waiting for no one to reply, but it is getting you a little chance to figure out if you know these terms or not. So dysuria is painful urination. Urinary frequency. Yes, this is associated with urinary stasis or urinary retention. And usually it's not that the person can't go at all. It's like they can go a little bit at a time, but they cannot empty the bladder. So that's urinary frequency. Urinary hesitancy. So this is difficulty in starting urination, and that's associated with prostate obstruction. Urgency, urinary urgency. Oh yeah, that's when you're my age and all of a sudden you just think about going to the bathroom and suddenly you need to go, and you need to go right now. So urinary urgency is the inability to control the sphincter of the bladder. You think I'm getting dementia because of that? Could be the first signs, and well, it's probably not the first signs and symptoms of dementia, but it could be. Urinary retention then is the inability to empty the bladder. All right, so we've got all those down pat, I'm sure. So the first thing that you really need to go over are the signs and symptoms of cystitis. If you'll remember, cystitis is a lower urinary tract infection. It's usually of the bladder or the urethra. So you're going to have urinary urgency, you're going to have dysuria, you're going to have nocturia. We didn't really go over nocturia. That was when you have frequent voidings during the night. Hematuria, which is where you have red blood cells in the urine. Pyuria is where you have infection in the urine. Usually cystitis can be associated with a low-grade fever. You're going to have suprapubic tenderness or fullness. You just know you have to go to the bathroom, but when you go, you just have little bits at a time that you go, and you don't have the feeling that you completely emptied the bladder. So what do we have to do to prevent UTIs or lower urinary tract infections? First of all, you want to take a shower instead of bath, and you want to wear cotton underwear, because the cotton wicks the urine, not necessarily urine, but any kind of wetness into the fabric itself, and then it will dry. You want to urinate after intercourse. If you're lucky enough to have intercourse, I'm just saying, you want to clean from the front to the back, and you want to drink 2 to 3 liters of fluid a day, because that flushes, that gives extra volume into the glomerulus, extra volume into the blood, which travels through the glomerulus, and you have excess water being excreted through the kidneys, and so that will kind of flush the urine. Okay, so there's a difference between urinary tract infections or cystitis and pyelonephritis. So what is the difference between cystitis, the signs and symptoms of cystitis, and those of pyelonephritis? Okay, you both have infection. So, but the people with pyelonephritis are going to be much sicker. So you're going to have fever and chills, which is always indicative of a higher fever than a low-grade fever. So you're talking about things above 100 degrees Fahrenheit. There's going to be this burning urgency and frequency of urination that occurs. Again, nocturia, same thing with cystitis, same thing, the burning urgency and frequency of urination. Let me just see what is happening to my thing. Oh, I've got an Amber Alert here. Wait. I have an Amber Alert on Saturday morning. Yes, at 7:47 a.m. There's an Amber Alert. Okay, back to this riveting lecture. Wait a minute, got to have a drink. I take you guys with me everywhere I go. Okay. Back to pyelonephritis, fever and chills, burning urgency and frequency of urination, nocturia. Okay, this, except for the fever and chills, you do have a low-grade fever with cystitis, higher grade with pyelonephritis, but you do have the burning and urgency with the cystitis. You do have the nocturia with cystitis, but you're going to have, instead of suprapubic tenderness over the bladder, where you're going to have discomfort and pain, this time you're going to have flanked pain that's in the back, or it can migrate down or radiate down into loin pain. But you're going to have a very tender CVA. You're going to have abdominal discomfort. And it can, because you're sicker, you're going to be more nauseated. You may even vomit. With both cystitis and pyelonephritis, you're going to have that general malaise or fatigue. But with pyelonephritis, you can have tachycardia and tachypnea. Then you need to report to the healthcare provider in case edema develops. And what does edema mean? Just asking. It means that the pyelonephritis has progressed to renal failure. So just be cognizant of the progression of the disease process and the signs and symptoms that are associated with that. Okay, you're now a urine analysis. So this with a UA, this is usually given to people that are suspected of having kidney disease. They sometimes want to rule out kidney disease is a way of saying that. But they're trying to look for what the components of the urine are going to be. Asymptomatic patients with renal disease may also have a UA ordered to determine how smart the urine is. And it may be that it's used strictly for diagnostic purposes when we're talking about some incidental findings that they have. For instance, person comes in, they have a broken leg or something, and they'll say, I haven't been peeing very well, or that type of thing. So again, this can be done by a CNA because it can be done with a dipstick. But I'm going to tell you a little secret about healthcare. Yeah, are you ready for that? Are you ready for that? I used to do, as a CNA, I used to do urine analysis all the time with a dipstick. But you know what? The insurance, Medicare, Medicaid services does not reimburse for nursing care. No. So anything a nurse does, yeah, they don't reimburse for that. So on a way to try and compensate for that, make money for that, the insurance, Medicare, Medicaid services will pay for lab work. So, hey, have the CNA collected, send it down to the lab. It takes quite a bit longer. It's more expensive to do, but hey, they can charge for it. Welcome to healthcare. All right, so let's talk about the components of the urine. First of all, we're going to talk about the color of it. We're going to talk about turbidity. If it's cloudy, then it usually means that there's an infection. We're going to talk about the odor, and it should be malodorous. In other words, it stinks like urine. Yes, it does. We're going to look for albumin. Should there be albumin? No. Ketones. Should there be ketones? No. Should there be red blood cells? No. Why? Because those molecules are all way too big to go through the filtration mechanism of the nephron. Bacteria will be there if there is an infection going on. Glucose, there should not be any glucose. Specific gravity, what is the range for that again? Hello? Hello? 1.002 to 1.035. All right, so if it's heavier, so if it's 1.035, then it's an indication that there's a lot, it's more concentrated. So if it's high, is the person going to be dehydrated? Yes. If it's low, does that mean that they're going to be in fluid overload? Yes. So we're just looking to determine again if they're suspected of having kidney failure, or they're just trying to rule out what the person's health status is. Okay, pH as well. All right, so Medicare and CAUTI. Ooh, I don't think I mentioned this in the lecture. So aren't you glad you're doing the review? Yeah, you are. So I got to tell you that CAUTI, which are catheter-associated urinary tract infections, are have been designated by the Medicare Medicaid Services, CMS, as which are in charge of reimbursement for long-term care, for hospitalizations, for anything that the government pays for its citizens. But it has been termed a never event. It shouldn't happen. If the patient is receiving the kind of care that we teach you about here at nursing school, then the patient should not acquire a catheter-associated urinary tract infection. It is more expensive to treat. The patient may have to stay in the hospital a little bit longer. But the CMS said, no, we're not going to do that anymore. Hospitals should be providing that kind of care. So Medicare, Medicaid won't pay for it anymore. So the thing about it is, this is the reason why at McKay-Dee Hospital, they do not let students insert Foley's anymore. And even since I've been here this has all happened within the last 6 years, because that's when I moved here. And at that time, students were allowed to insert Foley's at McKay-Dee. But since then, it changed to, okay, only a nurse can insert a Foley. And they still had too many CAUTIs. And so now it has to be two nurses, two RNs that are watching as a Foley is inserted to ensure that there is no breach of sterility or sterile technique. Again, this is such an expensive thing to happen to a patient because they require more medication and their hospital stay may be extended. So CAUTIs, remember, is the number one associated nosocomial infection. Number one, still within the United States. So hospitals are trying to minimize the risk factor for infections with catheters, Foley catheters, so they implement these different policies. So I did want to mention that to you, but I don't know how well it was covered in fundamentals, but it definitely is very costly for a hospital because hospitals make such a small percentage of profit that they can't really afford to be covering their with stuff that their nurses aren't doing correctly. All right. We then moved into renal failure. There's two kinds of renal failure. What are they? Acute kidney injury, and what else? chronic kidney disease, AKI for acute kidney injury, and CKD, chronic kidney disease. So you may see that in your doc, or use those abbreviations with your documentation. But let's talk about the signs and symptoms of acute kidney injury. First of all, the onset is very, very sudden. Happens out of the blue. You're peeing just fine. You're doing just great. And then all of a sudden, you start getting this flank pain a little bit, and you start decreasing your urine output. Or maybe you don't notice that. Maybe you start noticing that your feet are swelling, that you really can't get your wedding ring on anymore. So we recognize when this starts to happen, then we might start doing a complete metabolic panel, looking for laboratory data that would support a diagnosis of acute kidney injury. We know that with acute kidney injury that there's going to be 50% of the nephron involvement. And so it's either going to be 25% of each kidney, it could be 30% of one kidney, 20% of the other, but we just know that maybe 500,000 of those million nephrons are compromised in some way and aren't functioning that they need to. Now, there is an expectation that there will be renal function return with supportive care. We expect that it'll last maybe 2 to 4 weeks. Maybe a person will be put on temporary dialysis. We know that it'll last, 2 to 4 weeks. Anything less than 3 months is going to be considered acute kidney injury. So let's look at the difference between that and signs and symptoms of chronic kidney disease. So with chronic kidney disease, the onset is going to be very gradual. It's not going to be noticeable by the patient themselves, but this is when 75% of the nephron involvement occurs. And we refer to that as renal insufficiency. Now that can progress to 90%, and we consider that renal failure. So renal insufficiency is when the kidneys aren't doing what they need to be doing to meet the metabolic needs of the body, not getting rid of the toxins that they need. So there's going to be accumulation of toxins in the blood. But when the person has 90 to 95% nephron involvement that are no longer working, 900,000, 950,000 of those nephrons are no longer working, then we recognize that the person is in renal failure. And the thing about that is that renal failure is permanent. Yeah, it is. You don't get those nephrons back once they're gone. So these people are fatal without some kind of transplant or going on to dialysis. All right. So let's look at this and talk about things that can cause different renal injury. Now, the thing about it is, let's talk about the AKA here for just a minute. And let's talk about some of the different causes. Now, and this can happen as well for people with chronic renal disease, although with chronic renal disease, most of the time it's just due to age, if a person goes into this, or injury type of thing, because as a person ages, then their nephrons aren't going to work much anymore. But let's talk about the different causes. And remember, there was pre-renal, intra-renal, and post-renal. And really, if you think about it, pre-renal, you think how much blood that body needs, not the body, but the kidney needs in the glomerulus to pass through it to keep that sieve working to force toxins out of the blood into the filtrate. So what do we need? We need blood. and to blood and a sufficient volume of blood. Remember, the afferent artery is larger than the efferent artery, so we need sufficient blood. And with that afferent artery opening and closing as it should, then the blood pressure will be sustained to push toxins out through the glomerulus into the filtrate and begin the first step of urine production. So we need blood. So it only makes sense then that hypovolemia is going to be too low of blood pressure. Dehydration, there's not going to be enough plasma to add enough volume of the blood for the afferent arteriole to cause the pressure, hydrostatic pressure needed to push those toxins through the glomerulus. And we can define this that blood pressure needs to have a map of at least 60 milligrams and or millimeters or whatever it is. It has to be less than 60. It's still early, people. It's still Saturday morning, okay? Okay, so when we're talking blood pressure with prerenal cause for renal failure, if it's less than 60, then and this is true of all organs of the body, it's not just the kidneys. If there is a MAP less than 60, there is not going to be enough blood pressure there to perfuse the organs of the body. Okay. So then when we're talking about intrarenal injury, we're talking about nephrotoxic drugs that can do that, that can destroy the kidney. And what did we talk about? We talked about aminoglycosides, we talked about cephalosporins, we talked about NSAIDs, we talked about X-ray dye for contrast dye to see what's happening with inside the body. So some people are allergic to it and really respond badly to that contrast dye. And so they can develop some kidney problems with that. Also with ischemia, and ischemia is going to be caused by what? By no blood. No blood, no blood. So what causes no blood? Again, the prerenal injury. So this is going to be a huge cause. The prerenal injury is going to cause the ischemic intrarenal injury. It's secondary to the prerenal injury. So associate the ischemic intrarenal injury with hypoperfusion, hypovolemia, dehydration, and a MAP less than 60. And then we talked about the causes for post-renal injury. And all three of these, again, are associated with acute kidney injury. So you have an obstruction of the urine that can't get out of the body. So you're sitting there, the kidneys all working fine, nephrons are all happy, but all of a sudden there's a kidney stone, or maybe there's an enlarged prostate that is obstructing the urethra and the flow of urine out of the bladder. And so the person ends up backing up the bladder, and then your bladder gets very, very congested. And we know from the gastrointestinal system what happens when there's backup. There's congestion, and so the kidney becomes very congested, and it can't make the filtrate anymore that it needs to. So now there's two phases of the ATN. I don't know why I'm looking at this big screen on the wall. Continue to do so. I don't know. Anyway, so there's two phases of acute kidney injury. Those were the causes. Now the phases are going to be that's not true. There's going to be 4 phases of acute kidney injury. So the first phase is going to be the onset. And remember, this can be unknown to the patient. They may not realize that they even have anything going on with their kidneys because it's too early. But the onset phase is basically that phase when the injury or the cause starts and then the effects of that cause are starting to happen. So again, that may not even be noticeable by the patient. And then the second point is going to be either a result of it's acute tubular necrosis, or it can be ischemic. So if we're looking at signs and symptoms of the we talked about the onset phase. The second phase is going to be either the oliguric phase or the non-oliguric phase. Now, you think about these terminologies to associate the signs and symptoms with what's going on in the kidneys. So, the signs and symptoms of oliguria for acute tubular necrosis is going to be no urine. Yeah, it's going to be less than 400 mils of every 24 hours. So it's less than 50 mils per hour. Oliguric, less than 50 mils per hour. So we got to realize that if the person ain't peeing, then the person's keeping all those toxins inside their body, including electrolytes, which includes potassium, which can cause cardiac dysrhythmias. Okay, so also in the second phase, it's either going to be ischemic, as we talked about, or it's going to be acute tubular necrosis that is oliguric or non-oliguric. So oliguric, again, is going to be less than 50 mils per hour or less than 400 mils in a 24-hour period. But the non-oliguric phase means that the kidneys have a greater input or greater output than 400 mils per hour. It's usually greater than 800 mils in a 24-hour period, but it's not doing what it should do. The kidneys aren't taking out all those toxins that they could be taking out. So then the third phase is going to be the diuresis phase, and that's where the nephrons perk up and they start pointing north, and they decide they're going to do what they're going to do. And so naturally, you've got all this excess fluid in the body. There's going to be a diuresis phase where you have this huge increase of urine production. And what we're trying to do there is going to get a lot of the water out of the plasma of the blood. So what happens here is think about this, is your specific gravity going to be dehydration? Is it going to be heavy or is it going to be light? Is it going to be less than 1.002 or is it going to be greater than 1.035? It's very dilute, so it's going to be less than 1.002. This is the diuresis phase. So at the very beginning, there's this huge outpouring. You're going to be peeing a lot. It's going to be very dilute, but then it calms down for the next 2 or 3 weeks and you don't pee as much, but the kidneys start filtering those toxins that they originally are supposed to do. Okay, so some of the diagnostic tests to determine glomerular filtration, right? Remember, the GFR in the kidney or in the nephron is indicative of how well the kidney's doing what it's supposed to be doing, because it is relative to the blood flow going through the glomerulus. So how fast that glomerulus is filtering all the toxins out of the body, which is the first step of your production, then that determines what the GFR is going to be. So the GFR, again, is indicative of how well the kidney is working. It is the diagnosis, or how fast the rate is for the glomerular filtration, comes from two lab values, BUN, which is the blood urea and nitrogen component of urine. And there's also the creatinine component to urine. Now, usually the BUN to creatinine level is 10 to 1. But if there is a dehydration problem where there's ischemia starting to cause the kidneys not to work, how do we know this? Because there's hypoperfusion. Hypoperfusion. So what we're going to do is look at the BUN creatinine ratio, and it's easy for that formula to be figured out because every person has a standardized amount of creatinine that they produce every day within the body for adults that have normal muscle wasting. And that results in a ratio of BUN to creatinine 10 to 1. But the interesting thing about creatinine that needs to be remembered is that it cannot be reabsorbed back into the body. Now, the BUN can. So what I'm saying here is during the filtration process, when BUN back in the glomerulus, the blood, the urea, the nitrogen that's pushed out by that high hydrostatic pressure from the blood pressure and the glomerulus, it gets pushed out, creatinine gets pushed out. But the difference is that creatinine never gets reabsorbed back in to the body through the tubular portion of the nephron. So once it gets pushed out, it doesn't come back in. So if you have exceeding high levels of creatinine in the blood, and I don't mean soaring levels, but just higher than normal range here, then what is happening here is that it initially is not getting pushed through the glomerulus into the urine filtrate. So if you have increases of BUN and creatinine in the blood, it means that the filtrate doesn't have those components because the kidneys aren't working. The glomerulus cannot filter those molecules out of the blood. There's not enough pressure there to make it happen. So if the BUN is high and the creatinine is high, that means the creatinine and the BUN are still in the blood. They're not getting filtered as they should. And if the creatinine is normal, so it's getting pushed through the kidney, but the BUN is increased, then what that is indicating that there is hypoperfusion there. It's not dramatic because the creatinine is getting pushed through, but there is a dehydration there because there's not enough fluid volume there to increase that pressure to push that toxin, the BUN portion, through the glomerulus, which is indicative of dehydration. So you need to know that a significant increase in the BUN and the creatinine indicates there is kidney failure. And I hope that you were able to look at that in clinicals this week. An increase of BUN without an increase in creatinine is usually indicative of dehydration. So if you're going to see, to confirm, you look and you measure the turgor on the clavicle or on the forehead type of thing, and you feel like there's tinting there, then you want to confirm that with a lab value for BUN and creatinine. which will determine if a patient is dehydrated or not. But if you are going to if you are going to request that there's a suspicion there, maybe the person comes in with a complaint of edema, feet are a little swollen, they can't get their shoes on very good, they're kind of tight, then we maybe suspect maybe they've got some acute tubular necrosis going on. So let's do a BUN and a creatinine. And if both are elevated, then that is indicative again of the tubular necrosis, which is kidney disease. So we talked about the onset symptoms. I don't think I talked about the recovery phase. Did I? I talked about the onset, which is the time of onset of the event until the tubular injury actually occurs. And then I talked about the oliguric phase, which is associated with ischemic acute tubular necrosis, and that is less than 400 mils in a 24-hour period. The non-oliguric phase was because of nephrotoxic acute tubular necrosis, and that was greater than 400 mils in a 24-hour period. We talked about the diuresic phase, where kidneys begin to work again and the patient diureses. It has this extreme large volumes of very dilute urine being produced, and then it slows down over 2 or 3 weeks, so that as the kidneys begin to heal. But then I talk about the recovery phase, and this happens when there is a rapid return to renal function, and that will be usually at the end of 2 weeks after somebody has acute kidney injury. This is not for chronic kidney disease. This is for acute kidney injury. So again, acute injury, acute kidney injury can be a temporary loss of renal function, the renal insufficiency, and the kidney can go back to normal and start doing whatever it needs to do. However, I think I mentioned that maybe a third of the patients have renal insufficiency, so they may never get back to normal, but they will get back to being able to function without dialysis. Now, with chronic kidney disease, this has been a progressive, prolonged time of kidney deterioration, and the body starts to not being able to maintain its metabolic balance. And so what happens here is that different parts of the body begin to be affected, and there's going to be a fluid balance affected, and a metabolic balance or an electrolyte balance that is being affected. And so in the very early stages of the disease, there is damage to the nephrons, but the patient doesn't have any symptoms. This is an asymptomatic response. With renal insufficiency, I think we talked about that there was a 75% of the nephron function is lost, and then with renal failure, we're looking at 90 to 95% of function of the kidney being lost. So end-stage renal disease occurs when there's 90 to 95% of the nephrons that are lost. The BUN and the creatinine are going to be elevated, and they're going to continue to elevate because those byproducts, or not byproducts, but those toxins are not being filtered through the kidney, and the patient will experience uremia, which is elevation of BUN. So there's two main causes here in the United States for chronic kidney disease. I think we've talked about that. The first is hypertension, and the other one is diabetes mellitus. And you think about those for just a minute, and hypertension is where the blood is coming so fast that the filtration process is affected. And then with diabetes mellitus, you got to remember that those glucose molecules are huge, just huge. And so that's very difficult. And normally they should not um, um, be excreted into the urine, but because these large glucose molecules are not permeable through the blood vessels, then it's kind of keeping other things from being filtered through those blood vessels as well. So what are the cardinal signs of uremia, which I just told you is an increase of BUN in the blood? First of all, the cardinal signs of it are anemia. What? I thought the red blood cells were not being filtered. Well, remember that they're not being filtered, but they remain in the blood there and they die. And so it makes it very, very difficult when that excess blood is not filtered through the kidney. And so you have your feedback symptoms that are indicated, hey, we got all the blood we need. Acidosis, ketones in the blood are going to cause the blood to become very acidic. And azotemia is when there's accumulation of urea. What is with my voice? It is just breaking up. What could be worse? Here we go. So azotemia is where there's an accumulation of urea and creatinine and other nitrogenous waste in the blood. So just know that anemia and acidosis and azotemia is are classic signs of uremia. So the complications of chronic kidney disease is hypertension. Why do you think it's hypertension? Because you're in fluid overload. Your water is not being filtered through the kidney and going into the collecting duct, or it doesn't become filtrate. So what happens? You have this huge volume of blood in the cardiovascular system, which is closed. And so you have this excess fluid, which is going to cause hypertension. So when you have a person that has hypertension, that's in chronic kidney disease, what are we going to do for interventions? What? We're going to fluid restrict them, and we're going to give them hypertensive medications to increase cardiac output a little bit or decrease it. I don't know what it does. I just know it's hypertensive medications. Yeah, that's a farm question. Don't ask me that. Okay, hyperkalemia, another complication of chronic kidney disease. So why is hyperkalemia such a problem? Yes, it can cause cardiac dysrhythmias. So people that have end-stage renal disease or chronic kidney failure as well, they are going to monitor their labs frequently. While they're in the hospital, it'll be a daily thing. Also, they're going to be on a renal diet, which is low in potassium and proteins. Yeah, they're not going to have a high protein diet at all because we can't filter those proteins out of the body. Proteins are very large molecules as well. We may give Kayexalate for hyperkalemia, and then hemodialysis can also help with our electrolyte balance. All right, so another complication that we're going to have that the kidney's usually in charge of is having a balance of sodium. So we're going to have hypernatremia, which is going to result in fluid overload. So anybody that has hypernatremia or high volume of or high amount of salt in the blood is going to be on a fluid restricted diet. So you say, okay, how much should we restrict the fluid? Who guesses that? Who pulls it out of the air? A much smaller person is going to have less fluids that they can take in during the day than a larger person. So how do we know the difference? What about somebody that's in end-stage renal disease and one that is just starting to have the signs and symptoms of chronic kidney disease? How much do we know? So this is the formula you use when trying to determine how much fluid a person in end-stage renal disease should have. They need yesterday's urine output, and then you add 500 to 600 milliliters of fluid or water that they can have, because 500 or 600 milliliters is what we allow for insensible fluid loss. Does anybody know what insensible water loss is? It's how much you sweat. It's how much humidity you lose when you breathe. It's just the normal metabolic function. So we account for 500 to 600 milliliters of fluid for that, and we add to that yesterday's urine output. That's what we restrict their fluids to. Now, that being said, how do we break that up? Because a person sleeps for 8 hours a day. This is the fluid restriction for 24-hour periods. So how much do we give them during the day? How much do we do at night? Because they're asleep at night. They're not going to drink as much as they do during the day. So usually we want to give them a half amount of what they can have during the day, and then a quarter and a quarter at night. Okay. Night and evening. Evening and night. What is it? Evening and night, I think, is what it is. Okay, but also we want to put them on a low sodium diet. We want to give them diuretics to help pee off the extra fluid. We'll put them in a high Fowler's position. Why do we want them in a high Fowler's position? Because we don't want that extra hyper volume of blood going into into the brain. Isonos, we want strict isonos, daily weights. If they're congested, then we want to use oxygen therapy as needed. We need to balance activity with rest because they are going to have excess weight because of the fluid overload, and so that may cause the heart to work more. They're going to have edema. We talked about the first signs and symptoms maybe in the lower extremities, but then they're going to go into systemic edema. The thing about it is systemic edema is different than the kind of edema that you have with heart failure. Systemic edema that you get with any overload has much more water in it, so it's easier to get rid of the fluid with diuretics than it is for the pitting edema that is caused by the congestion of blood flow throughout the cardiovascular system. But you are going to have JVDs, which is jugular venous distension. You're going to have sacral edema. So you've got to really watch that. If you want them with the head of the bed up, we need to be monitoring the sacral area all the time because that's going to be the dependent area of the body. And of course, offer hemodialysis to get those electrolytes and that excess fluid off. Okay, so I don't know if you remember back when Rachel was giving her little lecture on fluid and fluid balance and acid base and all that kind of stuff. But there's opposite. There's certain electrolytes that are inversely related. So with with phosphorus, there's calcium. Those are the two electrolytes that are inversely related. So if you have high phosphorus, you're going to have low calcium. If you have high calcium, you're going to have low phosphorus. Well, with kidney failure, you're going to have hyperphosphatemia and hypocalcemia. So what we need to do is limit our phosphorus intake, and we're going to give antacids, which are basically just chewable calcium, before every meal, because the antacids are going to bind with phosphate, which will increase the calcium in the body. Person is also going to be at high risk for metabolic acidosis. So we're going to put them on hemodialysis for that. Person may also have anemia. We talked about that earlier, because kidney failure. Oh, I didn't do a good thing of explaining that, did I? The excess blood cells that were in the body that lysed, and the body was decreasing production of it. Now we're going to give Epigen for any hematocrit level less than 30 to help with the production of anemia. We'll also give iron supplements and monitor for orthostatic hypotension. And of course, with any kind of anemia, doesn't matter what the cause of it is. We've already talked about this in our hematologic lecture. And that is that with any kind of anemia, there's going to be extreme fatigue. So we need to space their activities with rest periods. Bleeding, excess bleeding potential can happen with people that have renal failure because the platelets are defective. So you're going to have a potential for developing GI bleeds or have excessive bruising. So you always want to assess for melena in the blood. Melena in the stool. We're looking for coffee ground emesis. We're looking for anything that looks to be like the person is bleeding internally. So what are we going to do for them? We're going to put them on bleeding precautions. Yes, we are. And what are the bleeding precautions? Electric razor, soft toothbrush, no invasive procedures. If you're going to inject some medications, do an IM type of thing, then we want to hold or put pressure on that for a full 5 minutes. Yeah. And then we want to monitor lab values. And what lab values are we going to monitor? What? PT, PTT, INR, the number of platelets, albumin, all those kind of things. All right. Uremic frost was where you have the BUN, maybe out of the BUN, which is blood urea nitrogen, you have an excess of urea in the blood. And that may try to get out of the blood by coming and crystallizing on the forehead. It smells like urine. Yes, it does. So when you have that, remember with our pruritus. It's still Saturday morning, okay? I bet I'm up and you guys aren't. I bet you're still in bed. Anyway, pruritus here, remember that with jaundice, with the bile salts, which cause excessive itching. That's what's going to happen with this uremic frost. And so we want to use the same interventions. We want to keep the skin clean. We want to bathe with tepid water, and we don't want to use any lotions with alcohol. Okay, there's going to be an increased risk for infection. So we're going to have infection control precautions where we do teach our patients about hand hygiene and what the signs and symptoms of infection are so the patient can monitor themselves. And then neurologically, with the increase of toxins in the blood, the person is going to start exhibiting some confusion, They're not going to have an ability to concentrate. They're going to be drowsy. They're going to have lethargy. They may start to twitch because of high calcium. So what we want to do for them is limit as much as possible the protein intake they have so that it is high biological value, which will help prevent the buildup of nitrogen in the blood. Okay, we're almost through here. Signs and symptoms of fluid overload. Anybody? Anybody? Yeah. There's nobody out there. I'm talking to myself because it's Saturday morning and most normal people are still in bed under the covers. So I'll just answer this myself. First of all, there's going to be edema. It's probably what they're going to recognize first. And then there's going to be crackles in the lungs because there's going to be congestion. And why is there going to be congestion? It's because the interstitial fluid is going to be high, and so that will eventually migrate into the alveoli, which causes pulmonary edema. They're going to have weight gain. Yes, they are. You want to monitor daily weights because daily weights is the greatest indicator of fluid retention. Let's see. You're going to have jugular vein distension, and you may have sacral edema. All right, so we had some student presentations on hemodialysis and peritoneal dialysis and food intake. We talked about the food intake just a little bit throughout this review. So the rules for hemodialysis are, first of all, that before you put that person on hemodialysis, you want to obtain a weight and get their vital signs. Usually the biggest complication of hemodialysis is afterwards the person is hypotensive. They may struggle with orthostatic hypotension. So we want to make sure that we know what their vital signs are. We want to always assess her vital signs in the arm that does not have the fistula in it. We want to take their blood pressure when they are supine and when they're standing, and of course maintain aseptic technique. So during dialysis, we want to make sure that we take their vital signs every 30 minutes. We want to make sure that the dialysate line that is infusing the dialysate is patent because we want to ensure and we want to ensure that the connections are good and tight. We want to assess for clotting. We want to assess for shock. We want to assess for disequilibrium syndrome. And I think I asked this, maybe I didn't, but if I did, I don't know if I did or not. We always want to give medications after surgery, and there should be some kind of weight loss after the procedure, after dialysis. So again, we want to assess their weight. We want to assess their vital signs after dialysis. We want to make sure that the bruit is still buzzing along and palpate for a thrill if we need to. We want to report any pain or swelling or redness from the assessed arm. And we, like I mentioned earlier with vital signs, we never want to use the accessed arm for any kind of procedures. Do you want me to tell you a story? It's a true story. I will tell you this, that one of my students back in Oklahoma was a CNA for dialysis, and for whatever reason, her nurse allowed her to access the arm from the dialysis machine to the patient, and she noticed that there was a puncture mark in the vein on the same side as the access arm. So she went and told the nurse, and the told her, said it was no big deal. And so the CNA went ahead and hooked her up. And then right after the dialysis started pushing dialysate into the arm, the patient screamed, and the CNA went running over there, and the RN went running over there. And literally, that arm had been accessed the day before to draw labs. And so the vein was weakened, and now you have this dialysate coming in under pressure, and it just blew the vein right through the dermis. So it went right up to the whole arm. And so there was just this blood pouring out of this site. And the CNA would have felt like she was in such trouble, and she was. Yes, she was. And the nurse, I don't know what the nurse did, if she got fired or what, because CNA should have never been doing that, well out of the CNA scope. So I don't know what happened. It was just one of my students that it happened to. Just a little story. These things are true that we're telling you. There's bad things that can happen if you don't know it, because it's true, or believe it. Let me just say that too. So how are you going to know if a fistula is patent? You assess for a bruit and palpate for a thrill. I think we've just about done everything that we need to do. There was one thing way back here that I wanted to look at. Maybe I got y'all. Oh, okay. We didn't mention this. I went through this, but I just no, I did go through it because I remember I said ketones none, albumin none. I did say all that, didn't I? Okay, well, there you go. So I think I got everything. I know it's exciting, and I know it's especially annoying for you when I'm looking around because there's nothing to look at. There's this little white dot, which is the video camera on my computer, but it bores me, so I look around. I'm sorry, just have to do that. Must be annoying, but just let you know that's my review. And if you have any questions about that, please let me know and text me. And I know you're going to do fabulous fine because you're my students. Okay, we'll talk to you later. See you. Bye.